It is my great honor to introduce Dr. Mohammed Hamdi, who was for a couple of years the obstetrician gynecologist at Blackstone. He has stepped down from that position as of last Friday and is now in South County working with South County Hospital. But he knows us and our community well and has been a great friend and teacher, as well as somebody who does fantastic patient care. So I thank Dr. Hamdi very much for taking the time to come up and join us and to be with us again. We're thrilled to have him. Dr. Hamdi.
All right, thank you, Dr. Fine. Good morning, everybody. Morning. All right, so I guess that's the biggest number of men I've ever talked to. Anyways, so today I'm gonna be talking a little bit about some OBGYN things that you might encounter. Question before we start: how many of you had a delivery in an ambulance or did a delivery in an ambulance? How was it?
Messy.
Would you love to do it again?
No, if I had my choice, no.
Okay. Another question: how many are comfortable with OBGYN complaints when patients call with like heavy bleeding or something like that? I mean, obviously you get chest pain, headaches, but like OBGYN issues.
How do you mean comfortable?
Let's say if you get a phone call saying, like a 911 saying somebody is like hosing, bleeding like crazy and cramping, and she's like 35 weeks pregnant, is that something who's like, uh-oh, what am I gonna do with that? Say that again?
We don't like it, but we do what we gotta do.
Yeah. Well, I mean, of course, I mean, a lot of things that we don't like to do, but we have to do. Okay. So basically, what I'm gonna do today is we're gonna talk. I have nothing to disclose. We're gonna talk a little bit about OBGYN in general, and my goal from this presentation is basically to kind of like, not for you to be able to diagnose what's going on with a patient or figure out what's happening, as much as like what are important things to ask in each and every condition or situation that I think are very common, and basically kind of like figure out where those patients need to go. I know that you guys have exclusion criteria or things that have to go to an emergency room. They can't be done in a primary care setting, and we'll talk about these as we go. So we're going to be talking about our basically basic facts and terminology related to OBGYN. We're going to talk about general points. So for each and every case, we're going to talk about basic H&P, like what are things you want to ask the patient, what are things that you want to look at that might point you one way or the other, or you might be asked about when you call and say, well, I have this patient here. What are things that when you're calling me and asking me about that I would like to know, and you have those ready. We're going to talk about some worrisome findings in those patients. And then I divided this presentation into obstetrical part and gynecological part, and I'm kind of like going to go as like case-based. So, a patient called with this, what are important things? What should go in my mind when I get this phone call? And finally, we're going to talk in each section about red flags, things that should absolutely right away get to the hospital. There's no people are going to argue about that. No two people are going to argue about that. So we're going to start with a pregnant patient. The first patient is those people are pregnant. Just some basic facts about pregnancy. The duration of pregnancy is 40 weeks, and it's calculated from the first day of the last menstrual period. And the reason why this is kind of like I think is important is because if somebody calls and tells you, I'm pregnant, I've never done a pregnancy test, but my last period was like October 1st, and in your mind you know that this patient is probably around 9 weeks pregnant today, or 8 or 9 weeks pregnant. That can kind of like guide you where to go from there. Another fact about early pregnancy is that the uterus is usually in the pelvis behind the symphysis pubis up until 12 weeks of gestation. So if somebody calls and said, I just fell down the stairs or hit in the abdomen, I'm 10 weeks pregnant, that is not somebody that we're worried about the pregnancy. Nothing's going to happen to the pregnancy unless something happens to mom. So this is also something to think about. The other thing is, let's say this also helps us kind of like figure out how far along the pregnancy is. If somebody is like unresponsive and she's pregnant, you put your hand on her tummy and it's reaching, the uterus is reaching the belly button, we know this is 20 weeks. So landmarks for the pregnancy: symphysis at 12 weeks, belly button 20 weeks, and then sternum at 37 weeks, and in between basically goes in between, like 16 weeks is between the symphysis and the belly button, 28 weeks is between umbilicus and symphysis and sternum. So it kind of like gives you a rough idea about how far along the patient is. The reason why this is important is because managing, let's say, a trauma at 25 weeks is completely different from managing a trauma at, let's say, 20 weeks or 19 weeks or 12 weeks. Now, bear in mind that this patient is like stable and everything is fine with it from a medical standpoint. The other important thing is that term pregnancy is 37 weeks and not 40 weeks. A lot of people say, I'm like, I had a preterm delivery last time. I delivered early last time because I had delivered before my due date. Well, due date is the 40 weeks and the term pregnancy is 37 weeks. So somebody who's 37 weeks, 38 weeks, that's a term pregnancy. Any pregnancy less than 24 weeks is considered pre-viable, meaning that many conditions, one of the most common ones that we get all the time at women and infants, we get phone calls from rescue, from other hospitals saying, I have a 22-weeker who fell down the stairs who needs monitoring. Those people don't need monitoring. Monitoring is only for 24 weeks and up. And so that's because there's really nothing we can do for babies at less than 24 weeks. So a very important number to remember is that 24 weeks is the age where you need to make sure that baby is okay if there is an indication to monitor the baby. Anything less than that is not of importance. A pregnancy that ends before 20 weeks is considered an abortion, or medically it's called an abortion. People call it a miscarriage. And then any pregnancy outside the uterus is called an ectopic pregnancy. Any questions so far? All right, so whenever you're called for a patient who's pregnant, there are few questions that you always want to ask that nobody you're gonna talk to the patient about. They're always gonna ask you those questions. The first and foremost is that, does the patient know she's pregnant? I mean, many times we get to the emergency room, people brought in or coming in saying, well, I think I'm pregnant because I missed my last period. Well, have you had a pregnancy test? Do you have any proof that you were pregnant? The next question is, if you're pregnant, do you know how far along you are? And a lot of patients would tell you that, yeah, I think I'm this much or that much because she thinks that's what she is, or because they had an ultrasound, or they've been seen by somebody. So a lot of the patients who are pregnant will know, and it's also very important because somebody who's, let's say, like I said, is like 18, 20 weeks is different from somebody who's like 5, 6 weeks. Somebody who's bleeding at 5 weeks might not be as worrisome as somebody who's like 18 weeks and bleeding. Has the patient ever had an ultrasound and a baby was identified in the uterus? Somebody who calls with abdominal pain and spotting and already had a baby in the uterus is far less worrisome than somebody who never had an ultrasound and is calling with pain. And so whenever somebody calls on the phone and say, we have this patient here, she's having, let's say, right lower quadrant pain or left lower quadrant pain, let's keep the right on the side, left lower quadrant pain, but she already had an ultrasound and there's a baby inside, I'd probably see her in the office next day. But if somebody calls and say, we have this patient with left lower quadrant pain, she's having a lot of pain and she never had an ultrasound, and that could be an ectopic, and that can kill the patient. That's somebody who probably needs to go to the hospital right away, get an ultrasound, evaluate it, maybe go to the operating room. So those are very important. And then any other comorbidities, any other medical problems, any issues that might affect, the management of this patient. Anytime you're gonna call somebody about a pregnant patient, they're always gonna want the answers to those questions. So it's very important that we know these things when we see any pregnant patient. All right, so for a patient, you get basically a call, a patient, 26-year-old, 7 weeks pregnant, and she's calling with cramping. I mean, probably 70-80% of early pregnant patients we see in the emergency room at women and infants are basically coming in with this complaint. And basically for all these cases, what I'm gonna do is I'm basically gonna try to answer those questions. What are important things you wanna know? Why do you wanna know these things? What are pertinent findings? And what could be the differential diagnosis? Now, like I said, I'm not gonna go into the details of every diagnosis because that's not what you're going to do. But basically, what are important things to know and keep in mind when you're dealing with somebody like this before transporting those patients? Abdominal and pelvic pain, like I said, is extremely common in early pregnancy. And classically, the classic teaching is that anybody who is early pregnant who's having abdominal pain, usually with some spotting, if there is any spotting, is either an ectopic pregnancy or a miscarriage. But those are not the most common. The most common is actually just round ligament pain or just pain from early pregnancy, cramping of early pregnancy. And so it is so it's important for us to know initially whether that patient, back to that slide, the couple slides before, has the patient had an ultrasound? Does the patient know that she has a pregnancy? If the patient has a pregnancy inside the uterus documented, then that removes ectopic pregnancy, which is the only thing in this list that can kill the patient. Anything else was not going to kill her. Abortion is not going to kill her unless she's hemorrhaging. Round ligament pain is not going to kill the patient, but ectopic pregnancy can kill the patient. So the first question that we always ask the patient when she shows up in the emergency room with cramping was like, have you ever had an ultrasound? Has anybody looked inside your uterus and documented me? If they say, yes, I have a baby, I have a heartbeat, I'm significantly less concerned than if they say, no, we don't. Any patient, any patient who is having severe pain or is having bleeding or has no documented pregnancy on ultrasound should probably be seen in the emergency room. Any patient who has other findings that cannot be explained by pregnancy, meaning that fever, chills, severe nausea and vomiting, looking septic, looking sick, needs to go to the emergency room. Patients, like I said, with known intrauterine pregnancy, with no other symptoms, just maybe mild cramping, those people are probably good candidates for an office setting, a primary care setting, or an urgent care setting. Most of the times, those people do not need urgent ultrasounds for follow-up. They don't need anything more than just an exam and reassurance. So that's basically abdominal pain in early pregnancy. Any questions so far? All right. The second patient is somebody who is 26-year-old calling with complaints of nausea and vomiting. This is probably my least favorite patient in the emergency room. I spent, before coming to Rhode Island, I spent 5 years in private practice. I have never sent a nausea and vomiting patient to the emergency room. Yet, we see a patient with nausea and vomiting every day, not one, multiple ones in the emergency room, a woman and infants. And it is so frustrating because most of these people end up going home. Most of them don't need any workup, and they're actually consuming resources. I mean, you guys, when you bring them in, you'll probably not be able to respond to a heart attack. And but unfortunately, that's something we see all the time. A lot of these people, they don't know what to do. They've never been talked about what to do. They can't eat. They think baby's gonna die because they don't eat, and so they're just freak out and they come into the emergency room. This is something that is extremely common. However, it's extremely common only in early pregnancy. So when somebody calls at 7 weeks and says, I'm having nausea and vomiting, that's probably nausea and vomiting of pregnancy. Somebody calls at 32 weeks having nausea and vomiting, that is not nausea and vomiting of pregnancy. That can be something that can kill the patient. Sometimes preeclampsia, severe preeclampsia can present as nausea and vomiting late in pregnancy. So nausea and vomiting is a diagnosis of early pregnancy. It is a first and early second trimester diagnosis. Beyond that, that's a completely different diagnosis. Anytime there are other associated symptoms of nausea and vomiting, fever, chills, abdominal pain, anything like that, we need to make sure that there's not something else going on. But anybody who is just nausea and vomiting, most of these people should not go to the emergency room unless they're severely dehydrated, they're like tachycardic, they're lethargic, they can't move, they can't walk, then they would need IV hydration and stuff. But the majority of these patients don't need anything beyond just some medication that can be prescribed as an outpatient and some counseling on how to eat, how to divide their meals and stuff like that. So most of these patients can be managed as a primary care or urgent care setting. All right, moving along. 32-year-old, next patient is 26-year-old, 32 weeks of gestation, complaining of cramping. So this is also another one of these cases where we get the rescue calling saying we have this 32-weeker, she thinks she's in labor, bringing her over, and everybody freaks out. What if she's preterm? And then she comes in and she's on her phone on the stretcher texting and basically ends up being closed and long and goes home. And that's again also a drain and waste of resources. So what we need to know is that cramping is extremely common and extremely normal in the third trimester of pregnancy. This is actually something we like. Whenever somebody comes in and says, I'm having a contraction or a cramp every now and then, that's actually something good. I always tell people your uterus is a giant muscle. It is going to have some activity in it. As long as it's not regular, the patient is not visibly uncomfortable, most of the times these people can be managed as outpatient. The differential diagnosis basically include term or preterm labor, Braxton Hicks contraction. So sometimes it's hard to differentiate between those, but many times when when people call us on the phone and say I'm having contractions, I can tell on the phone what's going on with this patient. If the patient says I'm having a contraction maybe like every 15 minutes, I'm okay, they've been going on for 2-3 days, that is somebody that probably is not in labor or preterm labor and can be seen in an office setting. Versus somebody who's like, I'm contracting every 5 minutes, they're getting worse, they're not going away, I took a shower, took a couple Tylenol, I'm still having those. So it's important to ask the patient these questions, like, for how long you've been having those contractions? Are they getting worse? Are they the same? And then any other associated symptoms. Anybody with like regular painful contractions, especially if associated with, bleeding, leak of fluid, no fetal movement, those patients need to go to the emergency room. They can be managed in a primary care setting. Well, somebody who comes in and says, I'm having maybe like a cramp every now and then. It's been going on for 2 weeks. Nothing really going on for 2 weeks is going to end up being preterm labor, because you will end up having a baby if you've been contracting in preterm labor for 2 to 3 weeks. So all of these patients can technically go to an outpatient or to an urgent care or primary care setting. Things that should always go to the emergency room: active labor or severe pain. Like I said earlier, a couple of weeks ago, or actually a few months ago, I gave a lecture at Hasbro about emergency management of vaginal delivery, and we always say, like, we can tell sometimes just by looking at the patient if that patient is in active labor or not. And I mean, you'd see the patient just like uncomfortable, writhing in bed. She can't sit still. She's never gonna be on her phone. We can tell when you guys bring us the patient, when the patient is just sitting on the stretcher and she's perfectly okay, we know that the nurses can go in, can do their thing, and then we can walk into the room. So sometimes you're just looking at the patient, you can tell if this patient needs to go here or that. This is somebody uncomfortable, just doesn't look right. This is somebody that should go to the emergency room. Heavy vaginal bleeding. Anytime you have heavy vaginal bleeding, whether pregnant, non-pregnant, anytime it's heavy, that patient needs to go to the emergency room. If they're pregnant and they're having heavy vaginal bleeding, they definitely should go right away. Decreased fetal movement. Anytime there is decreased fetal movement, that patient needs to go to the emergency room or to an OB setup. The reason why is because there's a protocol for decreased fetal movement. Anybody with decreased fetal movement, they need to have monitoring, they need to have ultrasounds, they need to have testing that are probably not available in a primary care setting. Any trauma in pregnancy after 24 weeks, and like I said, assuming mom is stable, like she fell the stairs or the dog jumped on her or something like that, any patient with trauma after 24 weeks needs at least 4 hours of monitoring, and those patients cannot be managed in primary care setting. They need to go to the emergency room. And anybody less than that, no. And like I said, because they're non-viable, there's nothing we can do to the baby. We don't put these patients on the monitor. Somebody needs to listen to the heart, which can be done in a primary care setup or an urgent care setup. Anytime when you're taking the patient, that person is not comfortable. We get calls all the time from hospitals around or from offices and stuff, office and stuff, saying that I have this patient who's, let's say, having this XY complaint, and although we think it's simple, a lot of people are not comfortable doing, pelvic exams or doing gynecological or obstetrical assessments. I mean, we talk to ED providers that haven't done a pelvic exam in like 20 years. And so, although those are simple, if the provider is not comfortable doing that, that patient should probably go to an OB/GYN setting. Any questions? All right. So moving along, I'm gonna be finishing very early. The non-pregnant patient. Most of the times, non-pregnant patients are going to call either with abdominal pain or vaginal bleeding. I mean, those are probably 99% of the cases we see in the emergency room, where the patients are brought into the emergency room with gynecological complaints. Just a few basic facts. The length of the menstrual cycle is the number of days between day 1 and day 1 of menses. So if somebody says, I get my period every 10 days, but then she bleeds for 15, 20 days, and that's still in a normal length cycle, it's just prolonged bleeding. Menorrhagia basically means prolonged or heavy menses. Somebody who bleeds for like 15 days, that's called menorrhagia, even if it's light. Or somebody bleeds for 3 days very heavy, that's still called menorrhagia. It's just a fun fact is that the average blood flow during each normal menses is only 80 cc's. The rest is actually tissues. So the bleeding during each menstrual cycle is very minimal. So when you walk into somebody's, house or whatever, and the sheets are like full of blood, that's not normal. That can cause shock to a patient. It means that she's losing a liter of blood or so. That is not normal, because normally women only lose 80 cc's per month. The most The most common way to quantify the bleeding when asking patients is through pad count. So, I mean, even for us, there's really no way to really, unless you're taking all the sheets and all the pads and basically weighing them, and there's a formula to tell how much bleeding is in there, we usually use what we call pad count, meaning that if we walk to a patient, or if a patient comes in and say they've been bleeding for like 2 days, well, the first question is like, how many pads are you filling? And if they say I'm filling a pad every hour, that's for us, that's the cutoff for us. It means that this is heavy bleeding. Versus, yeah, I change my pad like 3 times per day. That's not heavy bleeding. It's perceived as heavy bleeding, but it's not an emergency heavy bleeding. The average age of menarche in the United States is 12, and the average age of menopause is 50. And around those ages is the most common time where you're going to have patients complaining of irregular bleeding, and that has to do with ovulation and skipping ovulation and having, anovulatory cycles and breakthrough bleeding and all these things. So the patient, this is a patient who's 48 years old. She's calling with irregular vaginal bleeding. And same thing. What are the things that we need to kind of like ask for, because we know that when we're gonna call about those people, that's what we're gonna be asked about. First and foremost, need to know is that this is one of the most, like I said, the most common gynecological complaint, and I think it's the most common reason why women seek gynecology care. Most of the times, the bleeding is really minimal. In the past 3 years, I've been working at Women and Infants Triage. I probably had less than 5 patients that we had to admit to the hospital or do something acutely like a blood transfusion or something like that, because they came in with vaginal bleeding and they were symptomatic. Most of the times, these patients are having mild bleeding and it's not an emergency. The other important thing is that most of these patients need workups that cannot be done in the emergency room. Whether it's an endometrial biopsy, whether it's an ultrasound. Remember, if somebody's bleeding acutely or bleeding heavily, ultrasound is not going to be a good time to do an ultrasound. You're not going to be able to assess the cavity. It's just going to be full of blood. So ideally, those patients need to be evaluated later in the office in an outpatient setting. So really, taking a lot of these people that we see in the emergency room should not be seen in the emergency room. They should probably be seen in an office or a primary care setting where the workup and the treatment can be initiated. So unless the patient is acutely bleeding profusely, like she called and said, it just started now, I've been filling a pad every half an hour, I'm bleeding through my clothes, I'm bleeding through the sheets, those patients can probably be seen very safely in a primary care setting and not in an emergency room with the OBGYN. Like, I don't even put IVs in those people. Unless the patient is really older and they've been bleeding for so long, I don't even get a CBC on them. And so that's why that kind of like reinforces the fact that these people can be seen safely in a primary care setting. The last one is a little bit different. So the last one is somebody who's 22-year-old and she is calling for a sudden onset of severe left lower quadrant pain and with nausea and vomiting. So same thing, and the reason why I included this is because I've been talking a lot about patients who should not be seen in the emergency room, but I wanted to kind of like give it like a different flavor here. So usually when somebody calls and say, or they show up in the emergency room and somebody who's young with acute onset of unilateral pelvic pain, there are a few things that come to our mind. The number one is ovarian torsion. It would give you a sudden onset of unilateral severe pain, nausea, vomiting, all these things. Second thing is ruptured ovarian cyst. And the third thing is they have PID. And obviously, for any patient we're talking about, there's always the non-obstetrical reason for the pain. That patient can still be having a gastroenteritis, or somebody with right lower quadrant pain can still be having appendicitis. But I'm talking if we excluded these. So those patients should probably go to the emergency room, and the reason why is because if that patient has an ovarian torsion, that is actually something that needs to be addressed immediately. So somebody who has an acute onset of unilateral pain or an acute onset of pain, especially if severe, especially if associated with nausea and vomiting, those people need to be seen in the emergency room. They should not be seen in an office. If they go to the office and then the office sends them for ultrasound, and then after the ultrasound they go to the emergency room, that ovary is dead. It's been long dead. So those patients need to be evaluated immediately in the emergency room. So red flags for the patient who's basically not pregnant. Anybody with severe pain, like I mentioned with the last case, especially if associated with other symptoms like nausea, vomiting, fever, those patients need to go straight to the emergency room. Anybody with heavy vaginal bleeding, especially if acute, you guys know if somebody's been bleeding heavy, but they've been bleeding for a long time, their body would adapt. And even if they're anemic with a hemoglobin of 6 or 7, they'll still be perfectly fine with no symptoms. But if somebody's bleeding acutely and their hemoglobin goes down from like 14 to 10, they're going to be symptomatic. And so those people need to be seen in the emergency room. They need to be hydrated, resuscitated, all these things. Anytime we think there's pregnancy with heavy bleeding or severe pain, like we mentioned earlier, and obviously sexual assault. And I think I had a list of stuff that you guys are like need to go to the emergency room right away. You probably know these, I'm assuming, right? Yeah. So I mean, anytime we suspect there's sexual assault, those patients need to go to the emergency room. I call it green flags, but those are people that should never be seen in the emergency room. Somebody who's not pregnant with vaginal discharge. That's one of the things that pisses me off the most. Somebody walking in at 3 in the morning, especially when they call rescue, and I've seen it, and I know that you guys have seen it.
I feel you, Doc.
What's that?
I feel you.
At 3 in the morning, yeah, I'm having discharge for the past week, and it was like, okay. Spotting, like I said, especially if minimal, this is not, so those are non-pregnant patients. Vaginal discharge, that should never be seen in the emergency room. I'm talking again, non-pregnant. That should never be seen in the emergency room. Spotting or very minimal bleeding or chronic minimal bleeding, again, those patients should not be seen in the emergency room. When those patients walk into the emergency room, I go into their room and I tell them, you look fine, your vitals are fine, we're gonna send you home, call your doctor for a workup. I don't even check a CBC on those people because they don't need it. Those patients should be worked up as an outpatient or a primary care setting.
So how would we tell them that?
You don't.
They call 911 and they're like, oh, well, this is happening, and obviously we know what's going on.
So
how would we educate them?
what I was told is that you're not supposed to do that. Am I correct?
Do I tell them to piss me off?
You know, so when those patients, when that vaginal discharge patient walks in at 3 in the morning with 2 rescue guys and the stretcher and everything, I was like, why are you bringing her here? But then I realized it's not you guys. I mean, my understanding is that you have to bring anybody who calls in. Am I correct? Yeah. So
we can give them your number and then you can tell.
well, I would love to. You know, so at some point we even sometimes it's easier when the patient walks in. So you probably know. When this patient with vaginal discharge walks in at 3 in the morning, we still have to see her because that's the EMTALA, you know. We can't tell them, no, go to the office. So it is frustrating, but maybe if you guys have the option of basically, yes, Dr. Fine.
So here's what I think we're going to do based on this discussion.
Mm-hmm.
One is we're standing up a public communication campaign over the next 4 to 6, 8 weeks to help people understand what to use 911 for and what not to. So we're going to include vaginal discharge in that group. And the other thing is, I haven't talked to my colleagues, but it will be one of the new suggestions for inclusion criteria. So if it's on the inclusion criteria, that means that if somebody walks in and finds somebody with that complaint, they can bring them to Express Care at the new neighborhood health station.
Yeah, I mean, there's like a huge list that I could come up with like 4 or 5 diagnoses just right now of things that should not be seen in the emergency room, but can go to Express Care, and that's one of them. And unfortunately,
They should make an app.
what's that?
They should make an app so people such a folks can go on and be like, this is what I have. Okay.
I wish.
It's called
That is
Google.
a really interesting idea.
No, Google gives you all ideas.
Well, that's-
Google
that's
tells you
something
you got
that'll probably
cancer
work.
treatment.
Should I call 911 yourself, bro?
Yeah, but again, I think everybody's worried about the medical legal aspect of it. That's the issue. That's the issue. It's like, you mean, when they walk in, like I talk to those people, I know there's nothing going on with them yet. I still have to see them because medical legally and legally I have to see them. Chronic aches and pains. Anybody who basically is having pain or discomfort that's been going on for months should not be seen in the emergency room. I can't tell you how many times we walk into a room and the patient says, yeah, I've been having this pain here, it's been going on for 5 years. I was like, okay, well, 5 years plus 1 day, because I'm not going to do anything for it. Yeah, I mean, you can tell that there is some frustration in my voice because these things, I mean, we see them and
for 3 days.
yeah, I mean, exactly.
We wanted to give you guys a call.
You
I just
guys
can't take
have
it anymore. I can't
tolerance
sleep.
because of it.
And then you ask them what's the pain rate at 10:10. They're like, oh, I'm at 10, and
Yep.
they're on the phone like,
Yep.
it's just like, oh, yeah.
So what we do for these patients is that because the nurses would do the 10 out of 10, so we go into the room and we say patient, rates 10 out of 10, However, patient is on the cell phone all the time. I mean, that's how we kind of like defend ourselves, because you always want to make sure that when somebody else is reading your chart, is like you didn't send somebody home with a pain of 10 out of 10. So, but this is something that probably should never be seen in the emergency room. And you know, we see this all the time. It's like I've been to many doctors and nobody could do any. They're not believing me. They're not taking me seriously. It was like, I understand your frustration, but you're in the wrong place. I'm not going to do anything for you. The last one, in my opinion, and that might be a little bit, you know, kind of like controversial, STD exposure. I just found out that my boyfriend is cheating on me, so I came into the emergency room at 3 in the morning to get chlamydia and gonorrhea testing. Unless there is sexual assault, these patients can be seen in the office. It's literally a 10-minute office visit with a few minutes of counseling, and that should not be seen in the emergency room. Those people can be seen at primary care, you know, in any of these settings. The only exception, I would say, if somebody has absolutely no doc, which is not going to be the issue with express care, but I'm talking primary care, and then you really need to be seen. But like if it's not a case of assault, it's an STD exposure, we see these all the time. Patients walking in, especially over the weekend, asking for STD testing. So that is also something that should not be seen in the emergency.
And I'm also adding that to a draft inclusion criteria.
Yeah.
Because that's easy enough. And
Yeah.
that's something
Yeah.
you do at Blackstone every day.
Oh, yeah.
Day in, day out.
Yep.
Like your internet.
So I'm pretty much done. Any questions? Any questions you would like to ask? I left it kind of like a little short because I wanted to kind of like leave the opportunity for you guys to ask me about things, because you are the ones who get called, you are the ones who are evaluating the patients. I never get phone, I just see the patients. So I'm happy to answer any questions, you know, whether related to that or not. So yeah.
If we're in the field and like we experience something that the patient's telling us that they're not pregnant and they're denying any chance of pregnancy, but they're exhibiting symptoms of like, you know, possible like an ectopic pregnancy or an ovarian torsion or something like that. Like, where do we draw the line between transporting to, you know, women and infants without really any definitive answer to it being, you know, possible obstetric related, or versus like transporting to Miriam or something like that? Like, is that something we could call in to women and infants with and present the case? Is that something you prefer?
So, women and infants is gonna hate me for that. So, women and infants is a full emergency room, meaning that we are supposed, or I'm not there anymore, but we're supposed to see anything, anybody, and if we don't think that this is something that should be dealt with over at women and infants, then we transfer them out. So, if a man walks in, I'm supposed to see them and stabilize them, and it happens. So, I would say on the safer side. If you're getting called for somebody like this patient, and that's the reason why I included this one. If you're calling for somebody who's 22, she doesn't know she's pregnant, you don't have a pregnancy test on your vehicle, and she's having like severe, you know, unilateral pain, this is somebody that probably needs to go to women and infants. If this woman has a torsion or this woman has a ruptured ectopic, she can die, okay? And those two things are not going to be dealt with at Miriam or in a small hospital with no OB care, okay? While if it's somebody with, let's say, a right lower quadrant pain, fever, chills, that can be an appendicitis. And that's somebody who should go to Miriam rather than somewhere else. We get a lot of phone calls about that all the time, you know, and they always call us like, hey, do we come to you or Rhode Island Hospital? Like, where do you want us to go? And many times they know, just bring her over to here. I mean, 32 weeks with a trauma, but she's awake and she's fine, no head trauma, bring her over to me. Somebody had a car accident, airbag deployment, 32 weeks, she's in a neck brace. No, don't bring her to me, take her to Rhode Island first. So some of these gray zones, even us, we stay on the safer side. Although I don't want to deal with somebody who ends up having an appendicitis, but if the story is more of like, no, doesn't have fever, no chills, no nausea, no vomiting, but she's having this severe pain, she's missed her period for like 2 months, there's a chance she's pregnant, has an ectopic, then women and infants. Yeah. Yes?
So, can you suggest good ways of trying to figure out questions you ask to sort out whether you think somebody's likely to be pregnant or not?
Okay, so most people who want to be pregnant will tell you I'm pregnant, and most people who don't want to be pregnant, they'll tell you I am not pregnant. There's no way I'm pregnant. So it's pretty hard, you know, and we see it both ways. The first thing is that's why I included the first few slides. When was the last period? If the patient says I have clockwork period, I get my period always on the same time, yet I missed it last month, there's a high chance she's pregnant. Okay, but if she said I just had my period 2 days ago, obviously this person is not pregnant.
And that's the case whether she thinks she's using birth control
Yes.
or not. Because one of the things I think we've all learned is that people often think they're using birth control more effectively than they really are.
Yes. So no matter, unless she doesn't have a uterus, oh, actually no, she can have an ectopic. Unless she's not having sex, there's always a possibility that the patient is pregnant. Even if they have their tubes tied, even if they're using whatever birth control there is. In the office, when somebody comes in with irregular bleeding or abdominal pain, no matter what birth control she's using, we always get a pregnancy test. There is always a chance any woman in the fertile age group can be pregnant until proven otherwise. So, like I said, the only is that I'm not having sex, and you can prove with certainty that she's not having sex. Otherwise, anybody should be assumed to be pregnant. So going back to the question of whether she's pregnant or not, if she's trying, like if somebody's like, I'm not on birth control and I'm having unprotected sex, there's a high chance this patient is pregnant. If the patient is missing her period, that patient is pregnant. Now, whether this is regular or not, I think is beyond what you guys are going to be asking. But if somebody said, I missed my period, my last period was 2 months ago, that is somebody who can be pregnant until proven otherwise. And just to show you how difficult it is to really know by questioning if somebody's pregnant or not, anybody who walks into the emergency room at Women and Infants Hospital gets a pregnancy test. Because there is no definitive way for us to tell whether somebody is or is not pregnant. Even if they had their tubes tied, even if they had 2 IUDs, no matter what they have, they always get a pregnancy test.
Even if they say they had a period a week or 2 ago.
Yes. Oh yeah. Because that period can be a miscarriage, can be a threatening abortion. And so if somebody is pregnant and we see this all the time, we ask patients in the office, let's say for a pregnancy test, they say, no, I just had my period, 2 weeks ago. So she ends up being like 10 weeks pregnant, and that was just few spotting in pregnancy that she thought it was a period, and turns out being pregnant, she's pregnant.
I think the mistake I make more than any other time is to assume somebody is not pregnant without checking.
Yeah.
The only way I know somebody's not pregnant is if they have a negative pregnancy
Yes.
test.
Yes. Exactly.
And so in the field, a woman of childbearing age who has her own uterus, as far as I'm concerned, ought to be regarded as potentially
Yes.
pregnant until proven
Yes.
otherwise.
Yes, especially if she has a complaint that might be attributed to pregnancy. Absolutely. Yes. Any other questions?
What about a minor MVA? Let's say they were going down the street like 40 miles an hour, but they jacked down the brakes and they just love tapped the front one. So we got a 30-year-old female, 28 weeks pregnant. Is the seatbelt enough just to do damage, or?
Doesn't matter.
Okay.
So the problem with trauma in general, I mean, whether you had a car accident where there was an airbag deployment, or whether your kid jumped on you when you were sitting and it was just a minor trauma, anybody with trauma above 24 weeks, it's institution dependent, but the majority of the institutions, or at least women and infants, anybody above 24 weeks with any type of trauma needs to be monitored for at least 4 hours. And if they have enough contractions, they automatically get admitted for 24 hours. And the reason why this is happening is because one of the risks of trauma is abruption, which is separation of the placenta. It's extremely hard to predict with a trauma. And number 2, there are really no good quality studies that basically evaluate what is the best modality to treat or to manage patients with trauma. So that's why any trauma, no matter how simple it is, they always need to be monitored. The number of people who end up having an abruption is extremely low, unless it's a major trauma. But like minor trauma, but because there are no good studies and there's really no way to evaluate everybody automatically above 24 weeks and up, any type of trauma needs to be stabilized first. So, I mean, if it's like a major accident, they go to like Rhode Island Hospital or any of these places. But if it's a minor trauma where on the field you can tell she's fine, they need to go to Women and Infants or to a place where there's monitoring.
You say 24 weeks, you say?
24 and up, that's the age of viability, yeah.
What about anything under?
No,
And we
so
tried, now, this patient, we're trying to convince this patient that, how do we, it's
Yeah.
for their peace of mind, and they're
Yeah.
gonna wanna go no matter what we tell them.
They don't or they do?
No, they're gonna want to go.
Yes.
Correct,
Yes.
so, what do we do?
Yeah, so if I knew, I would have done it myself, because we see those people all the time at Women and Infants. So for these patients, so anybody less than 24 weeks with a trauma, what we usually do for them is we listen to the baby. I don't think, you guys have Dopplers on your vehicles? No. Yeah, so you have to take her somewhere. But those patients, I'm sorry?
I was gonna say that's above our pay grade.
Oh, okay. So those patients need to be seen somewhere. Don't get me wrong. So I'm not saying they can. If you think she's fine, she can go. No, she still needs to be seen somewhere, but just to document viability. And even if let's say you put the Doppler on and the baby is like heartbeat is like 90 or 60, there's nothing you can offer this patient. If you deliver this patient at 19, 20 weeks, the baby is not going to survive. So that's why we don't monitor those babies. But you still need to document viability for medical legal reasons, for the patient's peace of mind, for all these reasons. So, but she does not need to go to the emergency room for that if you don't think her injuries warrant that. What else?
Before we break,
Uh-huh.
we are handicapped in one way,
Uh-huh.
probably handicapped in many ways, but one is, with one exception, we're all men in the room.
Yeah, that's what I said.
So I thought it might be reasonable to give Deb Navarro, who's the Green Health worker running the Office on Health, an opportunity to ask you a question if she has one.
In a lot of the instances, like in a lot of the AMS reporting that I've come across, I noticed that in my part as a community health worker, what can I do in regards to the information that you have provided to educate these young women who are first-time mothers that are really unaware of the symptoms and like the process of pregnancy as a whole?
Yeah. So I mean, this is a very important question, and I think I don't know if you remember when I talk about nausea and vomiting of pregnancy. I said in 5 years of private practice before coming here, I've never had to send somebody to the emergency room because this is a normal symptom of pregnancy. And it just be managed with medications and outpatient and with just education and teaching. What I always like to tell patients, and we're talking about somebody who's low risk, has documented pregnancy, she has a pregnancy at the uterus, everything looks to be okay. I always tell the patients that pregnancy is a normal physiological process, you know, unless there is something really grossly abnormal that everybody's gonna be able to tell. Let's say heavy bleeding, severe pain, or baby not moving. Most of the complaints during pregnancy are going to be normal or would fit into normal physiology of pregnancy. You know, I'm nauseated, my heart is racing. You know, I'm crampy, I'm just tired. You know, I'm dizzy. All these are normal findings during pregnancy, and I always make sure to tell the patient that once they're past, you know, the first few weeks, once they have a documented pregnancy, that, you know, a lot of the symptoms you're going to have are just the normal physiology. This is normal pregnancy. There are going to be changes in your body. You're carrying an extra baby, and you're carrying a baby, and you're growing that baby. So, but to come up with like a list of everything, that's going to be a little bit hard. You know, I don't think that there's something you can like boom, 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 and by this list you eliminate all the visits to the emergency room. That's probably not going to happen.
So now in regards to, if we were to go a little bit deeper, in regards to the trimesters, depending on where the woman is there certain symptoms that I can provide and state to the residents, like, listen, these are normal symptoms during this trimester, unless ... whatever the case may be.
Absolutely. First trimester, nausea, vomiting, very, very common. Very normal. You are going to have days where you're not going to be able to eat anything, and your baby is going to be fine, you know, unless you get severely dehydrated, you go for days without being able to tolerate liquids and food, you're probably going to be fine. As long as you can eat small meals and you can tolerate some liquid, you are going to be okay. Baby's going to be okay. This is going to go on its own. Mild cramping is perfectly okay during the first trimester of pregnancy. Yeah, as long as, like I said, the pregnancy is documented, since at the uterus everything is fine. So some mild cramping here and there is perfectly okay during pregnancy. And even if it's a little bit, I don't tell patients this, but in the back of my mind is like, because there's really nothing I can do for it, you know? Second trimester basically is the trimester where you're going to tell patients, you're going to start feeling more heavy, you're going to starting with the back pain, with the discomforts of pregnancy. Any contractions or any discomfort that's unusual for you, any fluid leak, I need to know about it. Second trimester is the time when pregnancy is viable, but it's too early and you really want to act fast. If you think somebody's in preterm labor at 26 weeks, you really want to get them in right away because you want to stop that labor. That 26-week baby, if they're born, they can have a lot of issues. So this is what the trimester when you very, like if somebody calls me at 26, 25 weeks and I'm having cramping, I always tell them come in to be checked. Third trimester, 28 weeks and up, I start telling patients, the more you advance in this trimester, the more you're gonna hate that you're pregnant. You're gonna start having, back pain, feeling heavy, I can't breathe, can't sleep on my back. This is the most common. The most common is cramping. Some contraction and cramping is perfectly normal. I actually tell patients, I like to know that you're having some contractions because that's what's gonna prepare your cervix for the delivery. So having some cramping and contraction is perfectly normal. Anything that is regular, that is very painful, or that's getting worse as time is passing, you can time it, not going away with shower, with Tylenol, with rest. That needs to be addressed right away. Anything other than that, if you're contracting but you're sleeping through them, they've been going on for 2 days, that's probably nothing to be worried about. Okay?
One question, I'm sorry.
Yeah, no, go ahead.
Now, post-labor,
Uh-huh.
say a woman calls, says heavy bleeding, and she had a vaginal birth, and what in that case, what would be considered normal
Okay.
during a post-labor?
Okay. So in general, anytime the patient says, I'm soaking more than 1 pad every half hour to an hour is considered abnormal. Okay? So the first question is when somebody is calling with bleeding. Remember, when patients leave the hospital after delivery, they're not bleeding heavy anymore. So any change from that should be addressed. So if somebody calls and says, I left the hospital and I was just having some mild discharge and now I'm bleeding and passing clots, that's somebody who we always ask them to come in. Whether they're having some retained placenta, whether it's like some a laceration that opened up, those people always need to be seen. The other way we look at it is, if somebody calls and she's like 10 weeks pregnant and having some bleeding, worst case scenario, she's having a miscarriage. There's not much I can do for it. A lot of the times the miscarriage can finish on its own. If the bleeding is not heavy, I said they can be seen in an urgent care setup because nothing really can happen down the road without the patient really noticing it. But if somebody calls me postpartum and says, I'm bleeding, I'm passing clots, in my mind, if there's a 1% chance that this patient has a retained piece of placenta, she can get infected in a day and become septic and die. So I would rather see that patient, okay? So although the two are similar, bleeding and bleeding, but one of them can be more catastrophic than the other because of what could be there. But to go back to your question, we always use the pad count. Anytime you're soaking more than 1 pad every half hour to an hour and it's soaked, or it's just doesn't feel normal. This is her second or third baby, and this is not normal. Just coming to be evaluated. And in all honesty, a big number of those people who come in postpartum end up having something. We keep a lot of those. They end up having retained placenta. Something is always going on with these people. They always come in the right way. Nobody who has a newborn wants to go to the hospital. So they always come in, they have something going on. Yeah.
Other questions?
I have a question.
Yeah.
You're already doc.
Uh-huh.
Rescue's coming in, whatever, 26-year-old female, no vital signs, says nausea, vomiting, let's say 15 weeks.
Uh-huh.
Would you like to see IV Zofran from EMS or just
No.
transport for
No.
EMS, depending on
Yeah.
something horrific?
Yeah.
Just transport the patient in for nausea, vomiting, no?
So, this is my own opinion. Okay, so other providers might manage this differently. What we do at Women and Infants is that when the patient comes in with nausea and vomiting, we check their urine ketones. You guys know what that is? So ketones are basically a substance that your body would start making when you get into a state of dehydration. That's just the simple answer. So if the ketones are positive, then we usually put an IV in them and hydrate them. If the ketones are negative, we give them a PO Zofran and send them home. Okay? When you bring that patient in with an IV already running and we don't really think that she needs it, then that's actually, she's staying more in the emergency room and taking the place of somebody who's in the waiting room who probably needs to be seen right away. So if you ask me my own opinion, unless you walk into the scene and she's like actively vomiting, you can't talk to that patient because she's so vomiting, she's so weak, she's tachycardic, she might be hypotensive. Mind you that tachycardia or higher than normal heart rate and lower than normal blood pressure are very common, normal in pregnancy, okay? And so, then yes, I mean, that's something that you can't just like lift off the floor and put her in an ambulance and not put an IV in her. But if somebody's just like perfectly normal, yeah, I've been vomiting for 3 days and you can smell burgers in the house, that's somebody who I would not put an IV in. I can't tell you how many times we see patients, I walk into a patient's room coming in with nausea and vomiting, and there's a bag of McDonald's because she tried the McDonald's, she vomited, decided to come into the emergency room for nausea and vomiting with pregnancy. It's true. I mean, we see that. So the answer is no. And like I said, the majority of these people don't need that. The majority of people need to be told that just PO hydrate at home, small frequent meals. Most of them don't need IV fluids. Because you're gonna put the IV fluids in, she's young, she's gonna get hydrated, she's gonna pee the fluid, go home, get dehydrated again. What are you gonna do? You're gonna bring her back and do another IV? So
Well, that's what it's
yeah,
about.
no.
I mean, 90% of the time,
they don't need it.
somebody you brought to the hospital on your first day with nausea vomiting has been in the day between, the day after.
Yep. They do that all the time. And at some point we're like, you know what? Just the nurses were just like, yeah, we'll put an IV and you go say hi to her and then you send her home. Some of them are just like, they frequently come in. Those people probably have never talked to somebody who really sat down and talked to them really well, or they just feel too weak. I mean, we know that there are other issues why people call rescue or go to the hospital, not just the medical reason. But like medically speaking, unless you think she's severely dehydrated, absolutely not. Many times we don't do anything for these people. Zofran, ODT, and then send them home.
So we're probably so like you said before, what we do in room with IV or whatever is keeping somebody in the hospital where you guys would cut them loose.
Yep,
Right.
absolutely.
Right.
Oh, most of them. Like the number of people that, so we see a huge number of nausea and vomiting of pregnancy. I believe I myself have admitted maybe like 2 or 3 over 3 years. All of them go home. Whether they need hydration or not, if they need if they're dehydrated, give them fluids, a bag or 2 bags, they feel better, we send them home. Because even if we admit them, we're not doing anything for them. That can't be done at home.
I think the whole nausea vomiting protocol, that's not on you, it needs to be replaced. Because people call, they threw up 10 minutes ago. Well, how long have you thrown up? Well, once.
Yes, exactly. I
You
completely
didn't
agree
even
with you.
swallow in the truck.
It's
Like dry eating.
Yeah,
Mostly
exactly.
education.
It's education. This is one of the. I mean, like I said, this is one of the most annoying things for me. I know those people are miserable, but this is something that can be averted with just educating those people and telling them what the expectations are, what they need to do.
Other questions?
Mm-hmm.
So I want to point out, you actually gave me a good segue. If you look at the exclusion criteria, pregnancy is not an exclusion criteria. There are some things that are part of pregnancy that are exclusions, like leading in pregnancy, active labor, and decreased fetal movement.
Yes.
But pregnancy itself, not exclusion. So somebody who's pregnant has a sore throat, not excluded. Somebody who's pregnant, who's got allergies, not excluded. So for somebody who's pregnant, just look at the inclusion criteria. As long as they're not bleeding in pregnancy, make the call.
I mean, like I said, pregnancy is not a disease. It's a normal physiological process. It's just normal physiology.
So I don't know how to thank you enough. That was a fantastic. Now we have to work harder to get you to come back to Central Falls. What we really need.
Thank you.
Thanks very, very much. Thank you. I want you to take a couple of minutes Yes, it's in the back. So a couple more things before we break. I wanted to do a little mid-course check-in. One of the things I'm learning is that our presentations don't take a full hour, so I'm kind of trying to jigger presentations a little bit so we don't have big breaks between presentations. I want to make sure we have some breaks, but not half-hour breaks. And the other thing is we have the opportunity to tune up a little bit, and I'm curious whether there are some things that you're interested in hearing about that aren't on the schedule so far. For tomorrow, we've got, I'm going to do high blood pressure, headache, and stroke, and I'll probably do a little quick unit on chest pain, how we think about chest pain in primary care. We're going to do musculoskeletal injury and back pain. Dr. Gutman's coming back for that. And then we're going to do a tour of 9 Chestnut Street and the neighborhood health station. On Friday, we're doing substance abuse. and we're doing mental behavioral health issues. Is there anything that you think has been left out that you want me to find some time to go over with you, or find somebody to go over with you? Anything in particular? Hearing none, we will proceed. But if there's something that occurs to you on the way out, grab it, and we can add something fairly easily. And I guess that is about it. I wanted to quickly go over the schedule for tomorrow, which I did. Again, high blood pressure, headache, and stroke, musculoskeletal injury and back pain, and then we're going to tour the neighborhood health station. I think we have a bus lined up to take us over. Jared, is that still in place?
Was that?
Bus lined up to take us to the neighborhood health station?
Bradley was supposed to be heading that up. She was going to get the housing authority.
All right. Well, and if we have to walk, we're probably, as long as it's not raining, probably won't kill us to
Yeah,
walk
I think we'll be all right.
to walk the 2 blocks.
Yeah.
Now that I think about it. All right. Anybody have anything else you want to add, subtract, multiply, or divide? Hearing none, let's break for today. Thanks for being here.
Thank you, Doctor.